and for monitoring replacement or suppressive therapies. This is just a tabulated thing summarizing what we've already discussed about these hormonal assays. Here, one more important thing I would just mention, that the linearity is important to decide on dilution reruns. Biological reference interval table I have just shown again to show that the pediatric reference ranges are different, and in the view of history of pregnancy, again TSH values as well as the total T4 values should be analyzed with the reference ranges for pregnancy. This table shows us the CLIA acceptable performance criteria. These CLIA performance criteria show us or tell us that there is an allowable variation or which is acceptable during performance of these tests, maybe on a rerun on a similar platform or on different platforms. For an example, I would just consider a sample with a median value of TSH as 5 milli international units per liter. When run on different platforms or sometimes even rerun in the same laboratory, is allowed to have a variation of plus or minus 2. So the values may come either 3, in the range of 3 to 7. And again the interpretation would vary, because if the value is 3, we would say that the patient is normal, the thyroid TSH is in the normal range and the patient is free of any thyroid dysfunction. Whereas if we report it as 7, that would indicate subclinical disorder. So again, that is one point which we should always remember while interpreting the values. Based on the CLI criteria, our lab has established these committed CVs for these different hormones, and as you could see, both our level 1 and level 2 controls are well within the committed CVs. This is how a typical EQA report looks like. In all the external quality assurance programs, what is seen is the variation amongst the different instruments or the different platforms available, and then amongst the participating laboratories. This TSH EQA report shows us that based on the platform which is used, all of us are aware that we use one of these platforms, and these are the ones which are commonly available. So the range would be as low as 0.32, or that can be detected as even reported as 0.484. If it is 0.392, the value of the TSH is low and the patient might have probably hyperthyroidism is the interpretation which we cut out of it, whereas if it is 0.484, it falls in the normal range. The same thing here we can see with the T4 reports. The values vary from a lower side value of 4.51, which may go towards hypothyroid state, to a higher side value which is 5.86, which falls in the normal range. The TSH and T4 relationship should be known, and 100-fold change in a TSH value leads to only 2-fold change in the free T4 value. And as mentioned by Dr. Phadke, there is a time lag in the pituitary TSH response after initiation of therapy for thyroid dysfunctions, at least 4 to 8 weeks. The same is seen in this graphical representation. In the hyperthyroid case, the free T4 which was on a higher side after initiation of treatment has fallen down well before the TSH values which are here have come down in the normal range. So this should be remembered. Discordant TSH and free T4 levels can occur in early phase of treating hypo and hyperthyroidism following an episode of thyroiditis, including the postpartum thyroiditis, and in presence of certain medications like dopamine and glucocorticoid. Antithyroid antibodies can be broadly classified into these 3 groups which are done or estimated in the laboratories. The thyroperoxidase antibody or antimicrosomal antibody, thyroglobulin, and the TSH receptor antibody, which can be again either stimulating type or inhibiting type. The indications of the antibody testing would be autoimmune in suspected autoimmune or to confirm the diagnosis of autoimmune thyroiditis. In cases of subclinical hypothyroidism, in cases with thyroid dysfunction during pregnancy and postpartum, more so to get an idea about the complications which may arise during the pregnancy, or even to know whether the mother can suffer from a severe postpartum thyroiditis. And the last test which I would like to mention is thyroglobulin levels. Thyroglobulin levels are indicated for follow-up of differentiated papillary or follicular carcinomas after total thyroidectomy. In cases where we are suspecting factitious thyroiditis, where we want to know the activity of thyroiditis, and in cases where we suspect thyroid dysgenesis as the cause of neonatal hypothyroidism. Now I think I'm expecting that this session would be more interactive. I will request Dr. Phadke and Dr. Golwilkar to join me here on the dais. Mic देना तिकडे. In our everyday laboratory practice, we come across several reports of thyroid where there is discordance between the T3, T4 and TSH values, or FT3 values and the T3, T4 values. And I have tried to get these cases out of the routine practice cases, which I would ask all of you to participate in getting to a diagnosis, because there are several cases where we cannot come to a direct conclusion just based on the routine thyroid function test, and may require certain additional testing. And so let us go ahead with the discussion. The first case here is that the T3 and T4 values are on a lower side and the TSH is much elevated. I suppose the diagnosis will be pretty much evident. Right. So the diagnosis is primary hypothyroidism. In such cases, the free T3 or free T4 levels also would be on a lower side. Antibodies, whether they should be done or not, definitely, but I'm just giving this scenario because in certain cases, we might have the antibodies which may turn out to be positive, where we can then comment that probably this is Hashimoto's thyroiditis. This is just a table enumerating the different causes of hypothyroidism, and as you see, autoimmunity or autoimmune thyroiditis is at the top, and then the iatrogenic causes like subtotal or total thyroidectomy or irradiation to the neck for some kind of cancers are the major causes, top of the list.